Harold was 71, retired electrical engineer, sharp man, the kind who'd built his own house, fixed his own cars, knew the wiring of his own bedroom lamps better than the electrician who'd installed them. For the past 8 years, he'd taken one small pink tablet every night about 30 minutes before bed. His doctor had recommended it for occasional sleep trouble in his early 60s. It worked. He kept taking it. 8 years, 365 nights a year, one pill at a time. Harold's wife was the one who noticed first. He'd started forgetting where he put his glasses 3 or 4 times a day. He'd walk into the garage and stand still, trying to remember why he came in. He'd repeat himself in the same conversation. He'd lose the thread of a sentence midway through speaking it. By the time they brought it to a neurologist, Harold's cognitive screen was abnormal. The diagnosis offered was early mild cognitive impairment, age-related, prognosis uncertain. The neurologist asked one question that the primary care physician had never asked. She asked for a complete list of every medication and over-the-counter product Harold took. When he mentioned the small pink tablet he'd been taking nightly for 8 years, she stopped writing and looked up. She told him gently that she wanted to try something. She wanted him to stop that one pill, find a different sleep strategy, and come back in 12 weeks. 12 weeks later, Harold's cognitive screen was meaningfully better than it had been at the first appointment. 24 weeks later, it was better than it had been 5 years before the symptoms started. His wife said it was like getting her husband back from a fog he'd been slowly disappearing into for years. The pill was diphenhydramine, the active ingredient in Benadryl, the active ingredient in ZzzQuil, the active ingredient in most over-the-counter sleep aids sold in every drugstore in America. It is one of the most prescribed and self-prescribed pills in the senior population, and it belongs to a class of medications that the published research has tied, with growing certainty, to long-term cognitive damage in adults over 60. I'm Dr. Okoro. On this channel, we walk through the published research on the medical decisions that matter most after 65. Today, we're going to walk through what an anticholinergic medication actually is, why the brain is particularly vulnerable to them after 60. The 2015 JAMA study that should have changed prescribing practice and largely didn't. The 10 most common anticholinergic medications that seniors take, many without knowing they're anticholinergic, the alternatives for each common use case, and what to do if you've been taking one of these for years. Throughout the video, I'll reference patient cases. Names and details are illustrative composites drawn from common clinical patterns. To understand why these medications hurt the aging brain, you need a piece of neuroscience that doesn't get explained well in routine medicine. Your brain communicates through chemical messengers called neurotransmitters. Several of them are well known: serotonin, dopamine, GABA. The one most relevant to today's video is acetylcholine. Acetylcholine is the neurotransmitter most associated with memory formation, attention, and learning. The hippocampus and the surrounding memory centers in your brain are particularly rich in acetylcholine signaling. Anticholinergic medications, as the name implies, block acetylcholine activity. They sit on the receptors where acetylcholine would normally bind, preventing the signal from being transmitted. Different anticholinergic drugs are used for different purposes. Some are used to dry up nasal secretions. That's why they appear in cold and allergy medications. Some are used to relax an overactive bladder. Some are used as sedatives for sleep. Some are used as antidepressants. The mechanism is the same in every case. Block acetylcholine somewhere in the body. Here's the problem. Anticholinergic drugs are not selective. A pill taken to dry up your nose doesn't only block acetylcholine in your nasal passages. It crosses the blood-brain barrier and blocks acetylcholine in your hippocampus, too. For a single dose, the effect is temporary and minor. You might feel slightly foggy, slightly drowsy. For years of nightly use, the effect is cumulative. The brain's acetylcholine signaling is suppressed, night after night, year after year. In a younger brain with robust acetylcholine production, this suppression is buffered. The brain produces more, compensates, recovers each morning. In an aging brain, acetylcholine production has already declined. The drug's suppression has a much larger relative effect. The recovery is incomplete. Over years, the hippocampus and memory centers begin to physically atrophy. The 2015 study that quantified this was published in JAMA Internal Medicine by Shelley Gray and colleagues at the University of Washington. It was a prospective cohort study. They followed almost 3,500 adults over 65 who were free of dementia at baseline, tracked their anticholinergic medication use carefully over years, and recorded who developed dementia during the follow-up period. The finding: adults with high cumulative anticholinergic exposure, defined as taking a strong anticholinergic at standard daily dose for 3 years or more, had approximately 54% higher risk of developing dementia compared to non-users. The relationship was dose-dependent. The more cumulative exposure, the higher the risk. A 2019 follow-up published in the same journal by Coupland and colleagues confirmed and extended the finding across more than 58,000 patients in the UK. Same dose-response curve, same magnitude of risk? A 2016 brain imaging study by Risacher and colleagues used MRI to look at structural changes in adults taking anticholinergics. The chronic users showed significantly more brain atrophy and lower glucose metabolism in the hippocampus compared to matched controls. The damage wasn't theoretical. It was visible on imaging. 3 studies, multiple research groups, consistent finding. The class of medications that includes the most used over-the-counter sleep aid in America is associated with measurable, dose-dependent, long-term cognitive damage in older adults. Quick thing before I walk through the medication list. The biggest reason patients don't know they're taking an anticholinergic is that the drug class is hidden across dozens of unrelated sounding products. A patient takes Benadryl for allergies and Tylenol PM for sleep and assumes they are 2 different medications. Both contain diphenhydramine. Both are the same drug at the same dose. The cumulative exposure adds up faster than the patient realizes. If you've ever taken any over-the-counter sleep aid regularly, drop a comment with the product name and roughly how often. I'm tracking the pattern in my audience. The data tells me how widespread this is. The 10 most common anticholinergic medications used by older adults. Recognize any of these in your bathroom cabinet. 1. Diphenhydramine. Active ingredient in Benadryl, Tylenol PM, ZzzQuil, Somanex, Nitol, Unisom sleep gels, most generic store brand PM formulations, and many cold and flu products. This is the most common anticholinergic exposure in the general population. Strong anticholinergic activity. Crosses the blood-brain barrier easily. 2. Doxylamine. Active ingredient in original Unisom, NyQuil sleep formulations, and some allergy products. Similar profile to diphenhydramine. Strong anticholinergic activity. 3. Chlorpheniramine. Active ingredient in chlortrimeton, some Advil cold and sinus products, Coricidin HBP, used for allergies, strong anticholinergic activity. 4. Hydroxyzine. Brand names Vistaril, Atarax, used for anxiety, sleep, allergies. Prescribed by physicians, not over-the-counter, but extremely common in older adults. Strong anticholinergic activity. 5. Oxybutynin. Brand name Ditropan, also generic, used for overactive bladder, one of the most commonly prescribed strong anticholinergics in the senior population. The cognitive effects of long-term use are particularly well documented for this medication. Alternative bladder medications with much weaker anticholinergic activity exist. Mirabegron is one, and should be discussed with the prescribing physician. 6. Tolterodine, Fesoderodine, Solifenacin. Other bladder medications in the same anticholinergic class as oxybutynin. Varying degrees of brain penetration, all should be reviewed if used long-term. 7. Amitriptyline. Brand name Elavil. A tricyclic antidepressant, often prescribed at low doses for sleep, chronic pain, or neuropathy in older adults. Strong anticholinergic activity. Many alternative options exist for each of these conditions. 8. Nortriptyline, doxepin, imipramine, desipramine. Other tricyclic antidepressants in the same class as amitriptyline. Varying anticholinergic burden. Some are weaker than others. Nortriptyline is generally considered milder. 9. Benztropine. Brand name Cogentine, used for Parkinson's-related tremor and for medication-induced movement disorders. Strong anticholinergic activity. The risk-benefit calculation is different here because the alternatives may be limited. 10. Promethazine. Brand name Phenergan, used for nausea, allergies, and sometimes sleep. Moderately strong anticholinergic activity. That's the most common 10. There are more. The Beers criteria, a published list of medications that geriatricians consider potentially inappropriate for older adults, includes dozens of anticholinergic drugs. Most American primary care physicians do not routinely consult the Beers criteria when prescribing for older patients. The information is publicly available. Searching Beers criteria 2023 brings up the current version. The alternatives by use case. If you're taking diphenhydramine or doxylamine for sleep, the alternatives include melatonin at 0.5 to 3 milligrams, magnesium glycinate at 2 to 300 milligrams, the bedtime ritual I discussed in an earlier video, protein and fat snack 90 minutes before bed, blue light cutoff, cool bedroom, and addressing underlying sleep disruptors like sleep apnea or restless leg syndrome. Trazodone at low dose is a prescription alternative that does not have significant anticholinergic activity and is considered safer for long-term use in older adults. If you're taking chlorpheniramine, diphenhydramine, or other first-generation antihistamines for allergies, the modern second-generation antihistamines, cetirizine, loratadine, fexofenadine, do not cross the blood-brain barrier meaningfully and have negligible anticholinergic activity. These are available over the counter and are roughly equivalent in cost. If you're taking oxybutynin for overactive bladder, mirabegron is a non-anticholinergic alternative. Behavioral interventions, including bladder training, fluid management, and pelvic floor physical therapy, work alongside or in some cases replace medication. Topical estrogen in postmenopausal women can reduce urgency symptoms. If you're taking amitriptyline at a low dose for sleep, the better tolerated alternatives are the same as for diphenhydramine sleep use. If it's prescribed for neuropathic pain, gabapentin, pregabalin, or duloxetine are non-anticholinergic alternatives. Discuss with the prescriber. 2 important warnings before I close. Do not stop any of these medications abruptly without a conversation with the prescribing physician. Some, particularly the tricyclic antidepressants, can produce withdrawal syndrome if stopped suddenly. If you have been on a strong anticholinergic for years and you have noticed cognitive changes, do not assume the damage is permanent. The 2015 study and subsequent research suggest that some of the cognitive effect is reversible once the medication is stopped. Harold's recovery is not unique. The brain has more capacity to recover than the early studies in this area suggested. The earlier you stop, the more recovery is likely. What to do this week? Step 1. Open your medicine cabinet and check the active ingredients of every over-the-counter and prescription product you take regularly. Look specifically for the 10 medications I listed. Step 2. If you find any, look up the medication on a reliable site. The National Library of Medicine's Medline Plus is excellent to confirm its anticholinergic status and read the older adult guidance. Step 3. Schedule a conversation with your physician or pharmacist. Bring the full list. Ask, which of these can be replaced with a non-anticholinergic alternative? The conversation typically takes 10 minutes. Step 4. If you take any of these for sleep, allergies, or bladder issues specifically, do not stop until you have a replacement plan in place. Stopping without a plan often leads patients to start the medication again within a week. With a plan, the transition is straightforward. Harold sent me a video at the 1-year mark after he stopped his nightly Tylenol PM. He's at a workbench in his garage, finishing a wooden cabinet he'd started building before the cognitive changes had made fine woodworking too difficult to enjoy. He wrote, "I built furniture for my granddaughter's apartment this year. I hadn't built anything in 5 years. I thought I'd lost it. I hadn't lost it. I'd just been swallowing it every night with a glass of water." If you take any over-the-counter sleep aid regularly, or any of the medications I listed, this is the conversation worth having this week. Not next month. This week. The pills have been on the FDA's caution list for older adults for years. The studies have been published. The information just hasn't reached most patients because the conversation rarely happens at the pharmacy or the primary care office. In the comments, tell me one thing. Are you taking, or has someone in your family been taking, one of these medications long-term? I read every comment, and the patterns shape the videos I make next. I'm Dr. Okoro. Take care of each other.